Hello, everyone. It's good to see you in the space today. My name is Peruth Navidie. I'm an organizer on the Global Campaign Against Racism. Just in case you were wondering on where to find the recording of our recent webinar on a new face of colonialism, death being a catastrophe affecting public health care, you're in the right place. I'm not the facilitator of this session. Mazo Sayuni is our facilitator of this session. And just to briefly say, Maza is a senior advisor for alliances and strategic partnerships at Oxfam in the US. And I think we will be having much of her taking us through the facilitation in the upcoming sets of our webinar. I would like to thank all those that supported us in this webinar, the speakers, the organizers. You all did a very tremendous job. Kindly allow me to inform you that in case you would love to know much about the political education and much of the discussions that relate with this webinar, please drop a comment and we will be following up on how to add you to our platforms or conversations under the campaign against racism. We will be having more of a series of this webinar, and please feel free to join us for more series to understand more about debt colonialism, racial capitalism, and all other related subjects under global health. Thank you very much.
Here to emphasize the fact that these loan programs, even when they say they don't do it anymore, they have merely undergone cosmetic reforms. They changed the names to not structural adjustment programs anymore, but at the core of it, structural reforms are still being pushed all the same in various forms. So as you may already be aware, there are strings attached to these loans. It's what we call conditionality. These conditionality are policies that governments have to implement to get the full disbursement of money. So they give the IMF give you money in chunks. Like for a first stage, in the next 6 months, you have to implement this, and then I give you another batch of money. So when they say like they're giving 500 million loans, they don't give it all at the same time. They will give like 50 million, and then subject to these conditions, if you meet the conditions, I give you another 10 million. If you don't, then we don't give you the rest. This is how they do it. So what do the conditionalities have to do with health? There are immediate effects. And immediate effects usually involves currency devaluation. We see this a lot in developing countries, especially in the 80s and 90s. So for example, the effects from this is that it makes imports, and developing countries imports a lot of medicines and medical technologies. They become more expensive because your money becomes cheaper. And so prices of also imported food also increase, and this worsens immediately health and nutrition, especially on children. And remember, when countries enter into this loan program, prior to the implementation of this policy, they're already in crisis. So a lot of people are already suffering, not being able to afford food, medicine, and such. And then there's privatization of health services. So it leads to less access to healthcare for lower socioeconomic groups, also for the rural areas, especially the poor and marginalized communities. And then there is deregulation. This impact regulations that govern the provision of healthcare services and social services in general. Also regulations that are meant to protect health workforce and general workforce as a whole, they have to be deregulated. So make less regulations to let foreign companies take advantage, make a, how to say it, an environment that is friendly to investments, they would say. Because when foreign companies want to come in, they don't like it when you have to put, when you have too many laws that protect the workers. They want the workers cheap. They want the workers to be easily, shaped to suit what they need so they can make profit. But let's not to, I digress a bit here, there. Let's move on to the most obvious. And when when people talk about the IMF, it's often about the austerity, because this is the main policy of the IMF. And they have been implementing this not just since the 1980s, but even prior to that. And this is a policy that has a root in even before the IMF was born. So there are international financial institutions prior to our political independence who had already pushed austerity on the colonies. Now, I also digress there a little bit. I'm just saying, for the current condition, what austerity do, the short-term impacts is quite severe, because it affects the numbers of health personnel. This would be reduced. Salaries of health workers would be reduced or frozen, so they cannot grow over the years as they're supposed to. Community and public health programs and services are also withdrawn, because these are part of the health services which are not profitable. When you put a lot of money into prevention, public education, you don't necessarily get something in return in monetary terms, although it is an investment to society. But this is not the stuff that they measure. And then there are also plan expansion for health system, but also for basic infrastructure that would be canceled, number of hospital beds and other health and social facilities, they would be reduced, sometimes even complete closure. And there would be fees introduced as a result of budget cuts, because these services and infrastructures need to be maintained, and they cost money. When there is no more money, then the excess of that extra expenditure would be burdened on the people. So now you have to pay money to access these services. And this is actually condoned by the World Bank and the IMF, the introduction of what they call user fee. So you pay fee to use services. There's also an effect because the overall government budget is reduced, then effect on national health coverage if it was provisioned by, say, taxes. And there are many more, actually. So this leads overall to reduce access and resulted later on to a multitude of health issues going unaddressed. But then I want also to talk about long-term impacts. Perhaps may also to touch on this, because we had also been observing some long-term effects on health from IMF programs that we experienced at the end of the 90s. Some programs from the IMF, they involve, say, decentralization of healthcare systems to make it closer to the local needs, which is not wrong per se, as it is. And this is modeled, how they advertise it, this is modeled by the Norwegian and German system that are a lot more decentralized and managed by the provinces, etc. But in developing countries, what happened was we do not yet have the resources and capacity to carry out decentralization. And then suddenly all these provinces and districts, they need to be independent on their own, manage their own, also raise money on their own. And that results in various of problems for coordination. And then especially provinces and areas that are poorer don't necessarily be able to raise enough money on its own without support from the central. And this is particularly important for, like I say, public health services and coordinations during emergencies. And then, sorry, if I'm speaking too fast, please let me know. And then there is also the medical brain drain as a consequence of austerity, which I would explain this later. Trade liberalization imposed by the IMF also create higher economic insecurity for poorer households. And then again, combined with like influx of, because there's open trade, there are a lot more products from outside coming in, influx of processed and cheaper food that are actually unhealthy. So unhealthy diets becomes common, and put this policy in place for decades. And then we are now seeing, the burden of obesity, cardiovascular diseases also in developing countries, right? And deregulation, I already explained before, and privatization of previously state-owned enterprises. So the thing that is rarely talked, because when people talk about, state-owned institutions being inefficient and slow and always under-resourced, and so it doesn't deserve to be kept running, it has to be privatized. But what also happens when you sell out state enterprises that belong to the people, the government also lose income in the long run, because these state companies would allow you to generate money and coordinate and regulate as you see fit to serve the people. So in the long term, this also actually result in less money to provide for health. I'm sorry, my slide is not moving. So I'm just going to touch on this briefly. And I think various civil societies have highlighted this, the gendered impacts of IMF programs, which is very obvious. And I would say, ladies, we have to be very, very angry with the IMF, because they create a situation that disadvantage women. Women's monetary contribution to the household economy become more critical, because there's less money going around, there's less work going around. So in every household, there's that increased pressure on top of already childcare and social work and family obligations, that you have to also bring income to the household. And this is especially true for women in lower socioeconomic level. But at the same time, these kind of policies also diminish women's chance to earn income by first creating unemployment in the formal sector. So women become more concentrated in lower paid, lower skilled work and informal sectors. And then you add cutting the national budgets for health and social care. This then, makes it even more difficult for women and girls. So I want to show you a little bit. I'm sorry if it's a little bit too small, the writing. This is a table that I took from a paper that I'm currently writing and plan for publication, because I'm doing a compiling of research, basically, of everything in academia that has discussed the International Monetary Fund's effect on health. And this is in our relationship, in our exploration of that relationship, we found that there is a compelling evidence concerning the link. So it's not just what we observe on the ground. We have had academic evidence on this. And it must be noted that IMF programs lead to, there is a significant association between IMF programs and the exacerbation of communicable diseases, maternal health issues, and neonatal complications, but also nutritional problems. And these happen most notably in sub-Saharan Africa. But also in higher income nations, we observe that they're not immune to these impacts of harsh conditionalities imposed by the IMF. We have observed in higher income nations a clear increase in injuries, suicides, when there is IMF programs in the country. So this shed light to the very complex nature and like the wide-ranging impact of IMF programs. And I mentioned before, trade liberalization, austerity, they have been correlated to, found to correlate with increased poverty, leading to increased malnutrition and also increased sexually transmitted diseases. So for health systems, how they impact the health systems, healthcare systems under IMF programs is very obvious. They would face troubling decline, and in turn, that contribute to decrease of overall population health, or worsening overall population health. And like I mentioned previously, it results in lower wages and professionals, deteriorating work conditions, especially within the public sector. And this combination of factors has led to significant and continuing medical brain drain in the country. But the effect is also not confined to the workforce. The budget cuts also had far-reaching consequences like diminished infrastructures over time, reducing the effectiveness of public health outreach efforts, and even for basic health services.
Dr. Diane?
Yes.
2 more minutes, please.
All right. So let's jump in to, I just want to give you example and keep note that I'm giving a bird eye view of Ghana and Kenya here. This is meant to complement what you have observed on the ground. As you can see here, medical illnesses in Ghana overlap with those happening in developed countries because of decades of trade liberalization and austerity. So to date, Ghana has undergone 17, imagine 17 IMF programs. And one just started last year. So why I'm highlighting Ghana here? Because historically speaking, Ghana is one of the countries who is eager to implement community-based primary care. But then decades of neoliberal policies imposed by the IMF and other institutions have stifled Ghana's progress to achieve it. So the provision of primary care remain far away from the population in need, contrary to the aspirations during independence. And also community health workers, they are limited only as extension of medical personnel and not becoming an agent of social change. And I forgot to find this map that was really interesting to me that shows the distribution of medical services in Ghana, which is very, very similar still to the colonial era, where the health facilities are concentrated in the southern section of the country, where ports and commercial centers and mines are there. And there is a continuation of this pattern, contrary to what they want to do upon independence. And then in Kenya, again, so many IMF programs since independence. And what I want to particularly highlight in Kenya here is the amount of foreign aid going to Kenya for health. Again, this is not something new. And this is not particularly unique to Kenya. There are many developing countries who are like this. And this is also a continuation of colonial era medical provision, which we had a lot of foreign aid back then, mainly to Christian missions. But, now there's a wide-ranging actors providing this aid and health services, which again is contrary to the aspirations of when we got our political independence, which is then to have our own country that we can run, a country that can provide health services to its own people. So I'll leave that there too for you to think about, and maybe we can discuss further. If you have stories from Kenya and Ghana, I would very much love to hear it. And I will just show you this. This is a document of the Alma Ata that aimed to have a health for all. And just at the beginning of that document, there is a part there that says all these changes for health for all it must be built upon a new international economic order. And what that means is actually the independence for a country to run its own economy and sovereign to make its own decisions, that it's best to protect their people. And there's a whole range of other things involved in it. But, I will leave that in your mind for you to think about. You cannot make radical changes for health for all without changing the international economic order. And I would like to believe that is why we're all sitting here in this room today. Thank you.
Thank you so much, Dr. Dian, for getting us started. As everybody knows, we will have time for questions after our two other speakers. So please note your questions. I see that there is also a question and answer box. So if you'd like to already start by putting some of them there, you are welcome to do that. So thank you, Dr. Dian. I'm now moving on to Dr. Danny Goto, who has more degrees than I can even note here. I'm looking at the bio that if we were to go into his full bio, we would be here for a long time. We're very honored to have you, Dr. Danny. He's a public health physician, health justice advocate, and human rights defender from Uganda, with a passion and commitment to the freedom for people of sub-Saharan Africa. He is going to give us a view from Uganda in particular, and we have here that your presentation will be analyzing the implications of the colonial debt on health locally with East African perspectives. Thank you so much for joining us, Dr. Danny, and please go ahead. Like with Dr. Dian, I will be timing you, and I'll give you, I'll jump in at 10 minutes to let you know that you have 2 minutes remaining. Thank you.
Yeah, Maza, can you hear me loud and clear?
Yes, we can hear you loud.
Great. I'm glad to be here, and thank you for inviting me and the organizers for this great campaign and ending date, and Diane for that wonderful preamble, introductory part of it. When I was invited to make a presentation, I remembered kind of 20 years ago when I was new out of school, very passionate. I was recruited into a campaign by Action Aid. Action Aid then was running a campaign to cancel debt. And now it is a full circle. We're coming back to the same place. We're still talking about debt. So when I was reflecting and I'm saying, okay, what happened to the HIPIC program? And then what the debt, what was canceled? How did these countries come back to the same place? So the question were baffling, but I recall a couple of years back when we were having COVID, when we were seriously doing some work around decolonizing health cooperation and critiquing development. One elderly woman, after making a very passionate plea for them to join our struggle, talked to me and said, how is this different from other conversations? And I'm posing the question to all of us. How is this debt cancellation different? Are we going to be at the same place after 20 years? She asked me also, decolonize then what? I couldn't answer quickly, but I understood her, pains, because somehow, somewhere, we're running in circles and the struggle seems to be continuing. And these struggles mean lives for so many millions of the people. So my presentation really is going to reflect on the Ugandan experience, more or less, and highlight how we've been navigating it, but also what the implication has been to the common day-to-day people. Uganda is, thank you, Dan, for giving the highlights for Ghana and Kenya. We have a very huge debt stock. Depending on whoever you listen to, the conservative estimate is that our debt stock is $22 billion US. That is way above the normally, paraded debt ceiling to GDP, over 52%. And when you look at the projections, much of the debt has been taken during COVID and after COVID. Actually, debt increased from $17 billion to now 22. The question is why? Then who is giving this debt? Now, I stop it at that. When you look now, and Diane talked about this very well, when you get the money, I will not, we've interrogated what does debt do? That there's a lot of issues there that needs to be unpacked. But for me, I want to look at Uganda's recurrent expenditure pre-COVID and then post-COVID. Now, the key highlight of those that slide is that interest payment is the highest expenditure for our budgets. So whom are we paying? Look at health, look at the social services, health, education, accountability, justice, law and order sector, the things that you need to transform a society, under budgeted or underfunded. What does it imply? That you have no money to run the state. Now, when we go forward and look at the per capita expenditure, I recall some years back, the Africans met in Abuja and had a declaration and said that for every budget, recurrent budget expenditure, we will earmark 15% of that towards health. Uganda, we are at 5%. And that is a conservative estimate. Sometimes even what is earmarked does not reach. If I look at the allocative efficiency, it is really, really low. Now, the other indicator, of course, the current health expenditure per capita as a percentage of GDP is equally low. So let's leave it at that. Going on. Of course, when we look at the current statistics and analysis from the WHO, they are saying that for us to achieve the universal health coverage, we will need to have a per capita expenditure of $114 per person. This is, of course, miserably very low, because when you look at the United States or any country in Europe, their per capita expenditure is way high. But for us, in Uganda, we only have, 59 per capita expenditure. Now, the gap is $54. Now, the impact of that, and Diane has expressed it very well, we have a stagnant maternal mortality rate, 323, 325. In some areas that suffer from high inequities, it goes high up to 500. The conservative estimate, if I would put it in a numeric term, Uganda loses 19 mothers giving birth. Just figure it out per day. As I speak now, by the end of this conversation, 2 mothers will have died. What kills them? Hemorrhage, sepsis, or congenital problems that exist pre-birth, or just malaria, which is taking a lot of our people. We struggle with teenage pregnancies, of course, contributing to maternal mortality. Infant mortality has remained miserably low, although we've done some efforts. So that is the story that we are grappling with. But if you relate with the second slide I showed you, the investment in health has remained constant. And the investment in debt repayment has always increased. Now, this is the picture of the facilities that I work with and support. Those are mothers. Those are mothers. If you cannot feel their humanity, then I don't live with you on planet Earth. They are waiting for healthcare service in a place. It was about 11 o'clock, about 2-3 months back. This is a public center. The health worker had not come because he walks very long distance, poorly paid or remunerated. Then he comes, opens up. They had come for antenatal. You can see them, some are, having their babies. Now, some, of course, because of the troubles that we have of HIV and other, health challenges, when they leave, then they can't come back, then they miss their dose, all right? Or if they come for refills, then they can't bring their kids for antenatal. So the reality is, without resources, our people are living a life that is not worthy any human being on this lovely planet called Earth. So I will skip that slide. Now, I wanted to bring this slide to show you, when we have problems, who are the guys coming in to rescue us. Now, they have designed a system that takes so much from our people. I've showed you that much of what we collect as a country is going back in debt repayment and interest payment. Now, these are the guys coming back with their investment. Now, if you critically look at this slide, you'll see that their investment is targeted to specific diseases of choice. In Africa, it is where we have neglected tropical diseases. Can you imagine that? Somebody called worth their name, coining a word called neglected tropical diseases. Who lives in the tropics? I want to ask anybody here, who lives in the tropics? And why are those diseases neglected? It is fundamentally one thing. The people who live in the tropics have this complex melanated skins. And then, who cares? They have to be neglected. These are not my words. Now, when you look at where the money is going, the biggest chunk of money is going into HIV. I don't want to unpack the politics of why HIV. I've been in the HIV sector for very many years. We've struggled to have treatments, but the leakages there and the promotion of particular medicines over others and stuff like that, I'll explain. But why are particular diseases that have limitations in crossing the borders of no interest? That one, I leave it to you. Now, when I was looking at the debt to GDP of countries, the shaded Africa, and I also mapped out the failures of the health system, you could literally see where there is failure of the health system, there is a very huge debt burden. So any person can see that there is a very huge connection. All right. Actually, when I was also looking at the disease burdens, you could also more like superimpose where there is debt burden to where there is disease burden. So those things move together. Now, this is my last slide.
Excellent, Dr. Danny, just on time.
Now, what do I see? I see that the debt burden, the debt coloniality has created dependency and created work for aid, because aid, charity, is business. I stop it at that. When I go to my Ministry of Health, there's something we're calling projectization. Diseases have been projectized. HIV, there's no focus on the health system. Everyone is picking their cherry. Of course, I mentioned briefly about the securitization of health and the global health problems. I talked about the neglection of some diseases and choosing diseases of importance because of some politics in there. The erosion of our healthcare system. Diane talked about migrations of health workers. I know WEMOS is doing a lot of, I've seen someone from WEMOS, they're doing a lot of unpacking what it means for health workers to migrate. Deanne also talked about austerity and what austerity has created. So therefore, to end, we are living in revelation times. This is a moment of reckoning. The world is raveling. Everything that has been hidden is in revelation for everyone to see. But we need everyone. We cannot create a world for those and those not. So let's come together and face power right in the eyes and say, enough is enough. Failure, we shall all sink like fools. I thank you. Lastly, I can't go without saying, I am pained. Actually, even coming to here today, I've been pained because of the troubles happening in the Middle East. It's not a conversation for today, but my heart and prayer goes out to the people of Gaza. I hope the world sees. I hope the world feels their pain.
Thank you. Thank you so much, Dr. Denny, for the rousing intervention and always, reminding us of the fact that some people's lives are listed as mattering more than others, and grounding us in those images and those important reminders. So thank you very much for that. And that was a great follow-up from Dr. Diane's presentation. We will now be moving on, and everybody, I remind you to please note your questions and your comments. We will have time at the end for discussion. I see comrades here who have written amazing reports on financialization and privatization of healthcare. I see colleagues who have worked on debt issues for a long time in the participant list. So I'm hoping that we can have a fruitful conversation after our third wonderful speaker, who everybody has been singing your praises to me, May Buenaventura, as I said, is in Morocco this week for the IMF and World Bank meetings. She's the debt justice program manager working at the Asian People's Movement on Debt and Development, and her presentation will, I think, give us some strategies for addressing colonial debts on health and related sectors, especially with a focus on Asia. So May, handing over to you, and I will give you a heads up at 10 minutes, and please remember to speak slowly. Thank you. May, you are on mute. There you go.
Okay. So thank you very much. And, I've been listening to Dr. Blandina and Dr. Goto, and I am extremely humbled by the wealth of information. We work generally on different issues, one of them being the rights to health and education, but I'm not particularly focused on the health sector, on public health, but it's very much part of our analysis on how these international financial institutions have really reached in deep into our societies in the global south. And even if we talk about conditionalities that happened like 10 years ago or 3 decades ago, these are the consequences that we're facing now of even more extreme vulnerabilities to shocks like COVID. So you have communities in Indonesia that cannot even afford to wash their hands at the time of COVID. So the simplest responses to COVID. Or in the face of climate change, the lack of decent housing, which also, of course, links to the right to health, the right to sanitation that's not so absent in many global South countries. And we see that colonial times seems also like, ages ago, like centuries ago. And there was a time when we did not use the term global health. We used to call it international health. And it was really clear I've been around for some time, so you might guess my age. So there was a time that it was called international health, and it was really clear how that it encapsulated that patronizing concept that the rich, that we are the burden of rich white countries, that it reflected a kind of white saviorism, that somehow we need the help of rich countries because we do not have assets or local knowledge of our own, that we were ignorant and so on. And so this seems like way, way in the past, but you can see it very clearly as well in this neo-colonial times of this approach that is rooted at that time. So again, we have the assumption that we need to pull ourselves up by the bootstraps under austerity. It's our fault. That's the assumption there. It assumes that we will also be saved by the rich countries. So the solution is almost knee-jerk, in crisis, that we've been hearing this even before the annual meetings. So if you're in crisis, that's the knee-jerk reaction: borrow more, borrow some more. So whether it's concessional terms or even in concessional terms, that's still loans. And so there's clearly a non-recognition of how the loans really led to a deeper indebtedness, dependence, and accumulation. As Dr. Goto said, he called to mind the HIPIC, and now we see almost the same set of African countries who were eligible then for HIPIC are again in debt distress. And Zambia, of course, was the first one to default as an after effect or a consequence of COVID. And now it has been bailed out again by the IMF. And we know what that means. Like Sri Lanka, that it's going to a painful process of following IMF programs, because that's what they're looking for. This is a guarantee that you will pay your creditors. So there's nothing here but debt as a business. How do you pay your creditors? The question of other social factors or indicators that connect to public health, like the climate crisis or the impoverishment, all those things do not go into the picture. The concept of debt sustainability is limited to your capacity to pay. So we are here in Marrakesh. We joined the protest march yesterday of civil society, and I also want to touch on what Dr. Goto said, as we've been calling for this since decades. And really, I mean, the struggle does not get easier. And I would like to take this also as an indication that we are shaking the walls or shaking the corridors of power, because there's a backlash. And so now we see a change in the kind of creditor profile. We're having more commercial private lenders on the table, which gives it more complicated terrain, because they really have no developmental mandate at all. It's really just what do we get out of it, profit-wise. So you see also countries that have such huge debts to private lenders. And this only means that the wins that we've won in the past were through struggle, and the kind of changes that we need in the public health system that we want will never be given to us on a silver platter. Just like human rights, we need to fight for them. So just to perhaps so that we're just always conscious that how we see these characteristics right now. So we see this also in the same top-down solutions as before. There's no consultation with local communities on actual need and actual conditions. There's also this trend that pushing like so-called magic bullet solutions without regard for other social determinants of health, such as access to food, water, shelter, and so on. And then improving the health is sort of instrumentalized, like linking to, oh, you should improve the health so that your growth will be higher. But the question is, what kind of, that's neoliberal economic growth that they're talking about. No? So it means that they want to really, the bottom line there is, how can you squeeze out more from labor? How do you do it more efficiently so that the exploitation and the profit from the labor is bigger? So it's not like you have rights inherent in you as a human being to health, no, but for these profit-driven motives. And also, perhaps also in Africa, shared also with Asian context, it's used as to win hearts and minds for political gain. Like for elections, they offer like free medical aid and so on, free medicines, and then they also offer it. They also withdraw it when the right to reproductive health, for example, comes in conflict with conservative religious groups. So that's what also happened in the Philippines, because we have a very conservative Catholic dominated institutions. So they use also they connive also with the local politicians to get what they want. And in all this, what is the role of the IMF, the World Bank, the G7 countries that control them, but also looking at development groups like USAID, no? And also the private sector and big pharma. So this is there's a really a powerful alliance there. They may not be named, but you can see really how they are complicit and how they collaborate with each other. And they've been governing the global health system for more than a century. So we need to realize that we are not, these are not small enemies that we're against, that we're dealing with. It's global. It's really deep. They're really deep into our economies, even up to women's bodies. And so much of our push as civil society and what we do well is really through organizing and campaigning. So we have our strategies of educating, campaigning, organizing. And we are really inspired by some of the lessons or the stories as campaigners, like, for example, in the Philippines, when they pushed for the privatization of the last remaining public facilities, our Philippine Orthopedic Hospital, and another facility that's the only public one dealing with maternal health care, alliances were formed. Patients, relatives, health workers, and the public at large. No? And with that push and with such energy coming from people against the privatization, we did kick out the corporation, the local elite that wanted to invest, to make it an investment, to make it a business. And so also there's also many stories of how our health insurance system, limited as it is, they wanted to use that to get the funds from that for a sovereign investment fund. But there was also protest raised against that. And in the end, it was removed from the sources of funds for this private investment fund that the Philippine government is setting up. In India also, there's many stories also of how they pushed back on PPPs, so privatization by any other name. We have this very innocent sounding public-private partnership, and it would seem that everybody is equal and on the table. But this very dangerous because privatization has such a wide range, no? From full divestment and to corporatization, where the facilities remain in public hands, but the way they operate it is like a private business. So you have user fees, and then you also see there how gender is really exploited. So since there's cuts in nurses and all, so it's the women, no? The sisters, the aunts taking care now of their kin in hospitals. And then, of course, during COVID, we really saw that the private sector could not do it because if no profit is to be made, no, So I think that was really made clear at the height of COVID, how you need strong public health institutions, and not only health, no, public institutions for social services for these situations that are not contingent on turning a profit. You really need the facilities, and you really need the power that we've invested actually ourselves in government through our taxes and our votes and so on, to look at these things that not only affect individuals but affect communities and societies as a whole. So I really would like, yeah, 2
I will
minutes.
ask you, yes, to wrap up, please. Thank you.
Yeah, I do need to wrap up. So I think my closing messages would, everybody I think knows it well that's in this struggle, because we're calling now. We're not here because we have illusions in the IMF or World Bank or the G7 changing themselves overnight. But we're here to maximize the attention on the annuals, to talk to the larger publics, that it's really through our persistence and our struggles that we've made gains in the past, and we need to continue doing so through bolder, as also Danny Goto said, a more solidarity across countries and within countries, no? Especially since the inequalities have also become sharper between those elites and the millions and billions of people who are without. So thank you very much, and happy to answer any questions.
Thank you so much, May, for that intervention. And we would like now to open it up to questions. I think for me, what everybody has said kind of highlights a quote that I heard recently at another session. Somebody was quoting Frederick Douglass, the US freedom fighter, who had said, "Power concedes nothing without a demand. It never did, and it never will." And I think that kind of goes to what May was just talking about, the need for solidarity and fighting together with our coalitions within countries, but also across regions. One thing that I find hopeful is that there seems to be more of the South-South collaboration growing, especially since, as everybody has noted, the pandemic really showed what was really missing. It was kind of like the tide went out and everything that we didn't want to see and people were ignoring was obvious. And now we have to prevent a return to normal, because normal was not working for any of us. So thank you for giving us some examples of things that have worked. I think important to note as people think about their questions is the reminder also that everyone from Dian to Dr. Dian, Dr. Danny, and May have reminded us that often it's the people who have caused the least harm that then pay the biggest cost, in the end, with healthcare, with climate, with debt issues, and also the irony of the countries that have stolen from so many other countries now being the ones that return and say, "I've stolen everything from your house, but now I'll sell it back to you for a profit," is sort of what it feels like. So we have about 20 minutes remaining, and I have no questions here in the chat. So I would like to encourage, if there are any questions. I see, oh, wonderful. Our colleague, Dr. Moga, is here. And Moga, I hope that now you should be unmuted, Moga. So please introduce yourself and go ahead and ask your question.
So my name is Moga Kamaliani. Can you hear me first?
Yes, we can.
Okay. So my name is Moga Kamaliani. At the moment, I am the co-lead for the policy group of the People Vaccine Alliance, but I've been working for decades about on access to healthcare, access to medicine, and all sorts of issues related to the issues you're talking about today. I just want to make two comments on the debt issue. One is about, let's not forget who actually took the debt, who took the loans. It is, okay, thank you.
Moga? Please speak a little bit louder, and just a reminder to please speak slowly. It seems we have lost.
Can you hear me now?
Yes, we can hear you now. You're loud and clear. Please just speak slowly.
Okay, right. Okay, so you just stopped my video, not my audio. Anyway, so yeah, so there was plenty of money available for the bank and IMF and other donors, rich countries, other banks, and they were really encouraging developing countries to take loans. So that's their side. They're still doing the same. They still are, encouraging loans, even with governments that they know are dictators or don't respect human rights or whatever. They just, it's as Maya said, it's a commercial thing. Give me money and I'll make profit. But on the other side, the governments go to these institutions, whether it's public or private or whatever they are, and ask for loans. So that's an important point that we have to really think about. The other thing, which is kind of related, is if we say drop the debt, I don't think we should say drop the debt without saying something about accountability and monitoring where the money is going. Because I think without that, we have no clue where the money is going. And it will actually, either us or our children or, other generations will incur more debt for no benefit. So we have to have good language, short and sweet, on accountability, on public scrutiny. So that's what we need, debt with public scrutiny. And just to say that, years and years ago, when I was working in Oxfam, we had, Oxfam managed to campaign in the UK and drop the debt on Uganda. But the condition was that the debt that was supposed to be paid to British and whatever institution should go to education. And there was a program that somebody sat in the Ministry of Finance to look at the money going to education. And meantime, what NGO like Oxfam did was they really monitored a particular, some places in Uganda, some governorates, some villages, to see, whether the school was built, whether the teacher got the salary at the right time, whether the kids had books and whatever. So I think that kind of monitoring from civil society is critical. The public, before the monitoring, the public scrutiny that says that people know that, okay, this country has dropped, I don't know, $100 debt from us. And these $100 are going to be allocated to the president's plane or schools or health centers or whatever it is. And then, we monitor, did that happen or not? I think without that, I personally cannot say drop the debt because I just don't know where it would go. I think it's really, really critical. So debt for health and education, I would say.
Thank you,
And my
Moga.
secret word, public scrutiny, civil society monitoring.
Yes, and I think the question there would be who's doing the monitoring, and I know that part of what this group wanted to highlight was that often the countries are blamed for things that really the responsibility lies with the lenders and the impacts that they're forcing on our countries. So yes, who's doing the monitoring and who are we blaming for issues? So I don't know if any of our panelists.
Can I just say one thing? But that should be part of our campaign. So when we talk to the IMF and the World Bank, they have conditionality about, cutting your public spending, doing that. So they have conditionality on the bad stuff. When it comes to good stuff, like link the debt release to, or the loan to health and education, they say, oh no, sovereignty, we can't touch sovereignty. but you can touch it when it's damaging people. So we have to be nuanced about what we say and really put that in our campaign. Public scrutiny should be part of the campaign to the north when we campaign the IMF against the IMF and World Bank and all these guys, but also to our countries. I'll shut up. Thanks.
So thank you. And I know, so some of what Moga has said is maybe slightly controversial. So I see that Dr. Danny has raised his hand, and we do also have Dennis from GCAP Africa here who has raised his hand. So Danny, Dr. Danny, I'll let you respond quickly to our colleague, Dr. Moga, and then we'll go to Dennis. Please go ahead.
Yeah, I think he raises very pertinent issues, and it's correct, the monitoring of the debt. But I come from a place of saying, why debt? Because when you answer that question and understand, debt is a band-aid. So it is not the solution. For instance, when I look at the numbers and I see illicit financial flows outside Africa, going out of Africa, Africa doesn't need debt. If we can plug the wealth being stolen from us, we don't need. I've just shared a paper published just this month by Dr. Rene from Zimbabwe. He highlighted classic empirical evidence showing how countries are leaking resources. So debt has been, created as a band-aid to a problem which is there and nobody wants to talk about it. If you look at the financial systems and how they work to steal from us, the mineral companies, the raw materials they are sucking out of Africa, we don't need debt. Actually, I don't care, even if they closed it yesterday and they no longer give money, provided they leave us alone to ensure that what we produce, we eat, what we produce, we use, and we're in charge of our lives. We don't need debt. How much is it that they're giving?
Thank you, Dr. Denny. Dennis, I see your hand is up and you have the ability to speak. Please go ahead and let's try and keep it brief. We know that with all her years of experience and her many thoughts, Dr. Moga, we give her extra time to express herself. But Dennis, please try and keep it brief.
Yes, good afternoon. I hope you can hear me. My name is Dennis and calling in from Zambia. I just wanted to share one aspect of the current debt situation in Zambia. Zambia, as you may know, we reached what they call, the debt restructuring, whatever. But if you read through the conditionalities, and that's where my interest is, there's one condition that has baffled and surprised all of us, because this condition says that once our economy begins to shape up and develop, it means that as a country, we'll be required to pay more to our lenders. So it means that our interest increases. And this is a framework which has been crafted, for lack of a better word, maybe sealed in a container with some nice wording such as debt relief. But how is this debt relief if at a time when we work so hard as a country, we try to free ourselves from this debt, the lenders also demand that we pay them more. So you can see the challenges that we face as developing countries, especially from Africa. This means that we remain in this debt trap. It's like somebody stealing from you in broad daylight. So even when we're analyzing this, one of the questions that we asked ourselves as civil society was, actually who was sitting on the table with these guys and negotiating and agreeing to such, terms of reference. So these are some of the issues, and I just wanted to bring this because of I think what Dr. Diani was speaking about when it comes to IMF policies, and also what Dr. Diani has also alluded to. I think we don't need debt. Really, if you look at this issue of debt, the way it has been crafted is that it's a trap. It's an issue whereby it has been made in such a way that you won't get out of it. Yeah, let me leave it here for now. Thank you.
Okay, thank you so much, Dennis. And I know that GCAP has been doing quite a bit of work about debt, yes, across the continent. And Dr. Dian, I see that your hand is up, and I would like you to take the opportunity to maybe, Dr. Denny, I think you've been able to express one final thought already as we're wrapping up on time, but Dr. Dian, I'll give you the opportunity as well, and then also maybe kind of a final thought as we wrap up. But I want to say that there are a couple of questions in the Q&A, one in particular saying, how do we even cure this malaise? From Masiwa saying, if we continue to be bound to this capitalist system, is it possible to begin thinking about another system? So that's something for us to keep in mind. As I say this, I want to remind everybody that our colleagues at Equal Health have set this up as the first of a series. So this is not the last time that we will be speaking about debt and the impacts of colonialism on the system. So please, if we don't answer all the questions today, remember that we'll have another opportunity. And I would encourage the three panelists to please look in the Q&A. If one of these questions here, either from the anonymous attendee or from Wasiwa Joseph, if you'd like to answer in the Q&A itself, please do that. But Diane, I'll hand over to you to respond and maybe give a final thought, and then May, you'll have the final word. Thank you.
Thank you, Mother. Just want to add to what Dr. Denny and the others have said. You don't need that. Yes, you don't need that. But I would also say you don't need aid, because debt and aid go hand in hand. You would say, I'm in debt. I cannot pay this debt because I need to pay for healthcare and education. And IMF would say, it's okay. We're going to give you aid for health and education. But the amount of money for aid that they give to you is actually even smaller than the profit that you expect expatriated to other countries, to the global north. It's not comparable. So essentially, it's just recycling money, where it's like, instead of aid, why don't you stop this money flowing out of the continent, the African continent, all the time, so we can keep it for our health and education. And then we don't need your aid. We don't need you to tell us what to do. We don't need you to tell us which disease to tackle first. We'll decide for ourselves. That's what I like to see. And I would just like to answer one question here about how mainstream the concept of debt cancellations are. Sadly to say, in the halls of power, this concept, despite the successes of the Jubilee campaign in 2000, has largely been increasingly forgotten. Now they are only talking about debt reliefs, debt restructuring even, that is a lot more common. There is this mindset imposed, and sadly, and this is also our mistakes, the business, political, and academic elites in developing countries increasingly also believe in this narrative that debt has to be paid no matter what. It's like it's a sin or something. But that doesn't have to be paid. This is the funny thing. And this is a concept that has been around since ancient days in Mesopotamia. That does not have to be repaid. It's also the responsibility of the lender to ensure that you can pay back this money that they're lending. It's not always the burden on the people who take the money. So that's for one. So that is one mindset we need to straighten out. And also debt relief. The Jubilee campaign was a huge success. We got $2 billion in aid, in debt relief. But this is despite its huge success, this was only a small portion to the whole of the deaths in the global south, 2 billion. And 50% of debt relief from that was actually only 50% will come from the IMF and the World Bank. The others are from bilateral debt release. Okay, Russia forgive their debts in Africa, China forgive their debts, and etc. You know, so this depends on geopolitical negotiations also, situation. But my point is, when we talk about debt relief, what they mean is relief. That's what they mean, relief. It's not what, because when we hear that relief, what people understand is like the debt is gone. It's not gone. They are only forgetting a portion of it, but they know there's a lot more that you need to pay. So you are still trapped. You're not free. Debt restructuring means you negotiate again for the debt to be paid later, but with increased interest, because the creditor now have to wait for you to pay. Before, when you agreed, you pay at this certain terms. Yeah, and usually there is even more conditionality. So we need to talk about debt cancellations and repudiation, because debt relief, debt cancellation, debt restructuring put the power of negotiation in the creditor's hand. Debt repudiation, on the other hand, puts it in the people's power. We don't want to pay this one. We're not going to pay, and there's nothing they can do about it.
Yes, thank you, Diane. And I may, before I hand over to you, I want to say two things. Something that I hope we can speak about at a future event for the colleagues who lead this group is the private lenders. May, you've touched on that, because they don't even abide by, you know, the debt restructuring and debt relief norms that are being pushed. So that's an issue that is taking up now a lot more space in the discussion. And I've seen a question here from Jovia Gonza asking, can we empower countries to reject repayment? Diane, as you've said, I have heard some regions saying that if the bigger countries, you know, band together and say, we three big countries in the region are saying we won't do this, then that gives power to the smaller countries. You know, it's hard for a country like Ecuador or a country like Zambia on its own to say no, but if we have big countries that band together and push back, so hopefully with the South-South collaboration, we'll see more of that in the future. May, I'm handing over to you for the last word. I know we're bumping up to the end of time. Please go ahead.
Yeah, so I'm happy to also update everyone that there's increasing more discussions around a South-South formation of borrowers. So that's been around for some time. And then we need to, of course, look at the context, because there has challenges of its own. But as Dr. Blandina said, debt cancellation, we would be much stronger with more countries taking that position. And I'm also happy that you mentioned debt repudiation, because it's also part of our campaign. While calling for debt cancellation, we cannot absolve our own governments. And we're also saying, stop paying, especially those loans that we call as illegitimate, because they violated human rights, including the right to health. And this is I'm very particularly proud of this discourse, because they used to laugh at us like, what is illegitimate debt? Everything is legal. But you know, this has been pushed, and it's reached the US, the UN, and there's now recognized as debts that really are so odious, whether they be dictator debts or so on, other kinds of debts that really you cannot ask the population to shoulder the burden of paying those debts. And so I also want to share that we're doing citizens' debt audits, which is a campaign strategy in itself that does monitoring and also identifying, like, not all loans, because that's a very big task, but just, a sense of the whole. Like maybe we identified before 20 projects that were, harm the communities and involve corruption. And we were able to reach Congress to say, you must at least suspend interest payments on these loans. So that means we can push it. We can push it up to those levels of campaigning. And I really like the debt audits because it involves people. And the discussion on debt is not left to experts, so-called experts. It dismantles the concept that this is a topic for finance ministers only or academics. And so everybody, what is the project in your community that has adversely affected your rights to water, health, and harm the environment, and so on. So we're doing that and hoping that the citizens' debt audits will be able to push the official debt audits, because government really has the access to the contracts and the books, no. So just as perhaps a last word, that also touching on what Dr. Danny has said about the illicit financial flows, I'll add just that how so much foregone revenue that we're giving through tax incentives, no? So it's really like a prescription that if you want more foreign direct investment, give more income tax holidays. But it's been proven not to work, actually, and we're losing so much through those incentives that were given to investors. And so that connects to seeing debt not only as an instrument of getting finance, but it's also really an instrument of ideological subjugation, because debt, if you look at it, it's really part of the cog of the machine of the capitalist system, a system that is so cruel that you see things like no pay, no hook. That's what they told dialysis patients in Manila. If you don't have the money, you don't get dialysis. So I think, even in those few words, you see that this cannot be. This is a system that we must dismantle. So thank you.
Thank you for ending us on that important note, May. We must dismantle the system. Thank you, everybody, for joining us and for staying a few minutes late. Apologies again for the technical glitches at the beginning and my scheduling error. I really apologize. I'm sorry about that, but thank you for sticking with us. This will be the first of a series by our comrades at Equal Health Campaign Against Racism. So I hope that people will join for the next one as well. Thank you to the interpreters. Of course, thank you to our amazing panelists, and thank you to the organizers. We'll see you next time.
Thank you.
Bye-bye.
Thank you for excellent moderation.
Bye-bye.
As usual.
Thank you, Moga.
Thank you.
Thank you.
Thank you.
Oh, May. Oh dear.
Martha, did you need me in?
I did. Yes, I had seen a note from Tinashe that the hosts and the panelists